Hello, I'm Thanos Dimopoulos. I work at the Department of Clinical Therapeutics at the National Kapodistrian University of Athens School of Medicine in Athens, Greece. And I will present an update regarding immune therapies for the treatment of multiple myeloma, focusing primarily on CAR T-cell therapy, bispecific antibodies, and antibody-drug conjugates. Recently, we had an update of the CAR-T2-4 trial. In this study, the cilta-cel product was compared to a standard of care in patients with relapsed refractory myeloma at early phases of the disease, 1 to 3 prior lines of therapy. In this particular study, we have now a long-term follow-up data, which indicate that there is a continuous improvement of progression-free survival in favor of the cilta-cel product. Furthermore, this progression-free survival advantage translated in an overall survival as well. Another CAR T-cell product is the ide-cel, and we have a similar study, the KarMMa-3 study, which compared the activity of this product versus standard of care in patients who had received 2 to 4 prior lines of therapy. And recently we had a long-term outcome of these patients. There was a progression-free survival advantage in favor of the ide-cel product. However, there was no an obvious survival advantage, and this was explained by the crossover design of the study. A significant number of patients who progressed on standard of care were subsequently crossovered at the time of relapse to the ide-cel product. Another very interesting CAR T-cell is the anito-cel, and we have preliminary efficacy data for this anti-BCMA CAR T-cell therapy in relapsed and refractory myeloma. In this initial study, we have patients who have been heavily pretreated. Many patients were pentarefractory. Many patients have received high-dose therapy. And the interest of this product is that there was not only a very high response rate with complete responses exceeding 60%, with high levels of MRD negativity, but also with low rates of side effects that we see with the use of CAR T-cells. For example, the rate of cytokine release syndrome was 1 or less in almost all the patients. There were no ICANS, and there were no delayed no ICANS neurotoxicity. And the potential explanation of neurotoxicity advantage of anito-cel is maybe thanks to its D-domain binder, which helps the therapy quickly release from the BCMA target and could help the product eliminate myeloma cells without severe immunotoxicity. So this is a very interesting compound that warrants further follow-up. There is a significant interest to develop CAR T-cells that have a different target from anti-BCMA, because we know that we have now many products that target BCMA, not only CAR T-cells, bispecifics, but also antibody-drug conjugates. So it is of significant clinical importance to identify other targets. One of them is GPRC5D. targeted chimeric antigen receptor T-cell therapy. This is particular of interest in patients who have been previously treated with an anti-BCMA-directed therapy. Flow analysis have identified 20 unique T-cell clusters with significant differences between responders and non-responders. The appropriate dose for this product was identified as 150 times 10 to the 6 CAR T cells, and this was the maximum tolerated dose. Furthermore, 75% of patients were previously treated with anti-BCMA responded to this product. So this is a very interesting approach, and as I mentioned, we are in need of CAR T cells that have a different target so that we can apply them to patients who have been previously treated with anti-BCMA therapy. Moving now to bispecific monoclonal antibodies, we know that there are already 3 of them commercially available for the treatment of our patients with relapsed refractory myeloma: teclistamab, talquetamab, and elranatamab. The approval of teclistamab was based on a large phase 1, phase 2 study, the MajesTEC-1 study, and this study now had the longest follow-up of a bispecific monoclonal antibody with a median of 30 months. Teclistamab continues to demonstrate deep and durable responses, including in patients who transition to less frequent dosing. And we can see a very high response rate. And also, we can see that the median duration of response for responding patients was 24 months, and it has not been reached for patients who achieved a complete response or better. Furthermore, with longer follow-up of teclistamabs, there were no new safety concerns. Of course, we know that with all bispecific monoclonal antibodies, we now administer immunoglobulins either intravenously or subcutaneously when the levels of serum IgG is less than 400, and this has significantly improved the tolerability and has reduced the rate of infections with bispecific monoclonal antibodies. Another important and approved bispecific monoclonal antibody is elranatamab, which again has been administered to several patients with triple-class exposed relapsed refractory myeloma. And we have here the long-term follow-up of the MagnetisM-3 trial, which included a large number of patients and confirmed the activity of elranatamab in patients with triple-class exposed myeloma. With 32 months after last patient and median follow-up of about 3 years, elranatamab was given at a dose of 76 milligram every week, and in responding patients, then the treatment was given every 2 weeks, and if response continued for 6 months or more, it was given every 4 weeks. The projected overall survival is 3 years. It is important to note that following switch from every 2 weeks to every 4 weeks, 96% of the patients maintained their response for 6 months or more, and the incidence of grade 3 and 4 infections decreased significantly. Thus, with bispecific monoclonal antibodies, it is important to decrease the frequency of administration for responding patients and also to administer immunoglobulins in order to reduce the well-known immunosuppression. Furthermore, of course, these patients are being treated with prophylactic antibiotics, antivirals, and antifungal agents. Talquetamab is the third bispecific monoclonal antibody which is approved for the treatment of multiple myeloma. It has a different target, a non-BCMA target, and also we have the long-term follow-up of Monumental 1, which is a study that led to the approval of this agent. In this particular study, a very large number of patients were treated, either on a lower dose given weekly or at a higher dose given every 2 weeks. The overall response rate was about 70%. And also, we noted, and this is very important, that patients who had received a prior CAR T cell, anti-BCMA CAR T cell, and relapsed had a 70% probability to respond to talquetamab. And also, patients who were pretreated with an anti-BCMA bispecific had a 58% chance to respond to talquetamab. The response rate to extramedullary disease was about 50%. We also noted that the every 2 weeks dosing was better, had a better duration of response than every week dosing, especially in patients who were naive to prior anti-BCMA therapies. Because teclistamab and talquetamab have different targets, there has been a study, a phase 1b/2 study, the redirect study, which has evaluated the combination of these two bispecific monoclonal antibodies who have different targets. This study established that the administration of talquetamab at a dose of 0.8 milligram per kilogram and teclistamab at a dose of 3 milligram per kilogram every other week was the recommended phase 2 dose. At this recommended dose, we noted a response in 80% of the patients. Furthermore, and more importantly, we saw a response of 60% in patients with extramedullary plasmacytomas, and we know that this is a hard-to-treat condition in patients with advanced myeloma. And also, at 18 months, 82% of patients with extramedullary plasmacytomas were free of progression. And this, with appropriate measures, such as with salt and water rinses, glycocorticoid rinses, were able to mitigate to a significant degree the taste disorder which is caused by talquetamab. So this is an important study that, of course, requires further follow-up in the future, and I would like to stress again the significant activity in patients with extramedullary plasmacytoma and the durability of these responses. Another new bispecific monoclonal antibody is linvoseltamab. This agent is being given intravenously, so the advantage of the intravenous administration is that it requires a shorter hospitalization because CRS is occurring earlier. So the intravenous administration is associated with an earlier occurrence of CRS and then subsequent shorter administration. In this particular study, linvoseltamab was given at increasing doses, and in responding patients, it was given every 2 weeks, and then after several months, it was given on a monthly basis. and this is, of course, important for patient convenience. At 21 months, objective responses were documented in 70% of the patients. The median duration of response was 29 months, and the median overall survival was 31 months. There was a response in patients who had high BCMA expression and also with less frequent administration every 4 weeks, there was a decreased risk for infections. So there was a favorable safety profile of this particular agent. Moving now to antibody-drug conjugates, we know that belantamab mafodotin is an antibody-drug conjugate that targets BCMA. After this link with BCMA, it delivers a payload in the interior of the cell and has multiple modes of action. In the DREAM-8 study, there was a comparison between a standard regimen, which is bortezomib, pomalidomide, and dexamethasone, versus the combination of belantamab mafodotin with pomalidomide and dexamethasone. The target population was patients who have been pretreated with lenalidomide. So this was an inclusion criteria, and I believe this is very important because now almost all patients with myeloma are being pretreated with lenalidomide, and also in this trial, patients with prior exposure to daratumumab were also included. So this is a study which address real-world patients with multiple myeloma. The primary endpoint was progression-free survival, with key secondary endpoints, response rate, overall survival, duration of response, and of course, tolerability. In this particular study, the majority of the patients were lenalidomide resistant, but also about 1/4 of the patients were previously treated with daratumumab. There was a significant improvement of progression-free survival in favor of the combination of belantamab with pomalidomide and dexamethasone versus PVD. The adverse event of interest indicated that there was no significant difference between the rate of myelosuppression. Of course, with belantamab mafodotin, we expect some ocular toxicity, which is usually consists of keratopathy of various degree. However, clinically significant ocular side effects that may affect the daily activity of the patients occurred in approximately 1/3 of them. And these side effects resolved completely upon holding the drug and starting at a lower dose. Another important study is the DREAM-7 trial. In this particular trial, there was a head-to-head comparison between daratumumab and belantamab mafodotin. Both of these drugs were combined with bortezomib and dexamethasone. Again, the primary endpoint was progression-free survival, and secondary endpoints, MRD negativity, overall survival, and duration of response. The patients that were included were typical of those with myeloma. Several of them had high-risk cytogenetics. About 1/2 of these patients had received previously lenalidomide, and 1/3 of the patients were lenalidomide resistant, and these characteristics were equally distributed between the two arms. There was a significant benefit in the progression-free survival in favor of the combination of belantamab with bortezomib and dexamethasone over PVD. And not only there was a PFS advantage, but also a more recent analysis indicated that there was an overall survival advantage in favor of the belantamab-based combination. Another important study is the DREAM-9 study. In this particular trial, VRD was used as a standard regimen for non-transplant eligible patients with multiple myeloma, and then belantamab mafodotin was given at different doses and at different intervals in several cohorts of patients. So as we can appreciate here, there were patients who started with 1.9 milligram per kilogram given every 3 to 4 weeks, or 1.4 given every 8 weeks. And there were several of these combinations that attempted to evaluate which combination is not only the more active, but also better tolerated with this quadruple combination. Cohorts with lower dose and longer schedules were opened to assess the potential to improve tolerability while maintaining efficacy, because we know that a unique property of belantamab mafodotin is that when you hold the drug, patients may continue to respond while the ocular toxicity is resolving. And these are the outstanding response rate that we observed, with responses ranging from 70% to 100% across all different doses. And we can appreciate that these responses were more pronounced for patients who started at a higher dose of belantamab mafodotin. These higher doses were associated with higher and faster MRD negativity. However, longer dosing intervals were associated with increased time to clinically meaningful changes in the visual acuity of the patients. Thus, not only we can induce a very high response rate in non-transplant eligible patients with multiple myeloma, with rates of MRD negativity that we have not seen before, but also by adjusting the dose and administering the drug at longer treatment-free intervals according to the ocular complications of the patient, we can manage for the majority of the patients to remain on treatment as long as there is a response of the disease. And based on this exciting data, there is a study that is comparing daratumumab with lenalidomide and dexamethasone versus belantamab with lenalidomide and dexamethasone, the DREAM-10 study. To conclude, CAR T-cell therapies are effective therapies for both early and late patients with relapsed refractory myeloma. There are, of course, several unsolved questions. For example, how sustainable are the responses? We know that the majority of patients relapse, but there are subset of patients, even later in the course of the disease, that remain without progression for extended period of time. And there is a question, is there a plateau in the PFS curve? For example, if we use these CAR T-cell therapies earlier in the course of the disease, may we achieve a cure in some myeloma patients? Furthermore, which are the best targets, which contrast, what dose? We know that dose is related to activity, but also may be related to side effects. Are different CARs similar? Is there a role for a second dose, either as a consolidation of the first dose or in the form of maintenance given several months apart? Is there a cross resistance? Are we losing the target? There are data to indicate that indeed, after several months, we may have a loss of BCMA, but we know that if the patient remains without therapy, then BCMA may reappear. What are the options after CAR T-cell failure? Are immunotherapies? Maybe the patients respond again to treatments that have received earlier in the course of the disease. And of course, apart from toxicity and logistics, the cost of this treatment may be a concern for several healthcare systems. Immunotherapy approaches with T-cell engagers offer excellent results in late relapse refractory myeloma. And of course, these products are being evaluated in the context of prospective randomized trials early in the course of the disease. The main problem is infections, and today we know that by using preemptively immunoglobulins, either subcutaneously or intravenously, and by using these drugs at longer intervals, we may, to a significant degree, decrease the rate of infection. Do we really need continuous use, or we may have a fixed duration administration of bispecific monoclonal antibodies? And finally, belantamab mafodotin in combination with either bortezomib and dexamethasone or with pomalidomide and dexamethasone are becoming a new standard of care in patients with early relapse refractory myeloma, combinations that can be administered to outpatients over a short period of time. They do not require hospitalization. They can be given every 3 or 4 months in several patients, and they are not associated with a high rate of infections. Thank you.